My name is Liz, and today we're going to look at our new pre-admission assessment form. This clinical record is useful for the inpatient setting when your intake team is evaluating if a patient meets criteria for admission to a psychiatric unit. Let's go ahead and open this up by clicking on it. It takes us first into the demographic page, which I've already filled out. So I'm going to move forward into the problem and screening area. If your patient is unwilling or unable to give a history, you can click this button. It'll put in a nice opening sentence here saying exactly that. Otherwise, you're going to come down to the presenting problems and pick one that works just like our shrubs do in the progress notes and in other types of complete evaluations. Let's start with psychosis and say that the information has been received from the patient and the family. This patient has psychotic symptoms. Is there a precipitant? There's a possible precipitant. Maybe this patient has been non-compliant with medications. Timing of the symptoms are now chronic. The onset has been rapid over the last several days. Signs described by others, maybe the family member says this patient's behavior has become disorganized or bizarre, and that there's a thought disorder. Symptoms described by the patient to you, maybe the patient says they're hearing auditory hallucinations, self-injurious command type. The severity I'm going to decide is high here. If the patients have prior episodes, you can document that very easily right here. Let's go back. If the patient has other presenting problems, you can capture those here. Otherwise, we can go forward into the immediate risk factors. Once again, we're going to have lots of options here. The reliability of the information, I'm going to say that we're unable to assess the reliability at this point. If the patient's suicidal, you can document that. I'm going to put down here that the patient right now is minimizing suicidal ideation. If there's been self-injurious behaviors, you could document that too. Maybe there's some dangerous behaviors. Maybe the patient has become aggressive towards younger children in the family, and this last occurred today. All right, let's come down here. We could talk about danger to others, if the patient's gravely disabled, or if the patient's going through medical or detox. But let's go back and look at the medical screen relative to this patient. Click on the shrub button. You can talk about the sources of information, maybe the patient and family members again. If there's a life-threatening emergency, you can capture that very quickly. I'm going to say there isn't one. If there's a potential medical emergency, maybe this patient has, let's see here, recent seizures. Let's go ahead and put that down. You can also do a pain scale and document the level of pain the patient's having if they describe that to you. If the patient has an infection or disease process going on, you can document that in detail. I'm going to come down here and say that this patient is currently positive for MRSA. An ICA note says, please provide some details. And I've made a custom button over here that says she remains positive for MRSA despite a 3-month course of treatment on vancomycin. Let's go back and move forward here into our current stressors for this patient. These are one-line sentences that you're going to push into the program. Let's say that there's just family problems. I'm going to click this. Mrs. Jones' family problems. Mrs. Jones describes family problems, and she experiences them as stressful. Details are as follows. Maybe your sister recently died. I'm going to show you how to spell check really quickly on the program. Let's come over here and do that. Let's come down here. If there were financial or health problems or legal problems, relationship or work problems, you could capture those as well. Let's come down here and look at symptom review for our patient who's acutely psychotic. Have there been any major life changes for this patient? I'm going to say a lack of energy and social withdrawal. Appetite disturbance is denied. Behavioral changes, let's say the patient is now aggressive and impulsive and displaying risk-taking behaviors. Mood disturbance, I'm going to say there's none. Sleep changes, maybe this patient's sleeping a lot. So I'm going to say normal length of sleep is 8 or more hours, and naps are taken during the day. There's a thought disturbance present, and let's go down here and talk about disorganized thinking. You can actually capture child and adolescent behaviors too, or withdrawal signs if you need to. Let's look at the patient's functional assessment. Is this patient ambulatory? Yeah, he's independent. Toileting is fine. Hygiene is partial assistance is needed. Speech impaired? No. Dyslexia? No. Writing impaired? No. Let's go back. Okay. Let's go over here to the next tab, past psychiatric history. Remember that these history tabs, past psych, medical history, social history, and family history, these 4 areas will be shared in any future complete evaluation. So anything your intake team captures under these 4 tabs will be pushed out to future complete evaluations of any kind. Okay, if past psychiatric history was negative or unavailable, you could choose this. If there's been a prior care setting, I'm just going to come down here and click prior psychiatric disorder and say that this patient has had psychosis in the past. And the age of the first episode was at age 21. I just typed that in. You can talk about the length of the episode, say that the patient's been treated with medications. Medications have been ineffective, and there have been subsequent episodes. This patient's a substance abuser, you can capture that. Psychotropic medications, maybe the patient's been on Abilify and Zyprexa. I'm just going to scroll down here to the bottom and click this in. You also have the ability to detail the patient's response to those drugs if you choose to. We can do an alcohol audit or a withdrawal history, but that's not pertinent for our patient today. I'm going to come forward and go into the medical history. If it's negative or unknown, you can click these 2 buttons. Otherwise, adverse drug reactions, I'm going to say that there aren't any. The patient also denies any allergies, no known allergies. If there's an active medical diagnosis, this is taken right out of our medical history tab in our other complete evaluations. Alphabetized by body type, maybe under cardiovascular, this patient's hypertensive, can capture that. If you want to talk about current medications, cardiovascular, maybe this patient's taking Lasix for the hypertension. We can talk about compliance, and this patient is compliant with the Lasix. You can talk about who the medications were prescribed by. Female issues can be captured here. Pregnant, not pregnant, birth control. Birth control is used. LMP was, I'm going to click in here, 4 weeks ago. Okay, you can talk about health and behaviors, past medical history, what the patient's pharmacy is. I'm going to use a custom button to pop in Bellflower Boulevard, the CVS pharmacy on Bellflower Boulevard. Talk about primary care provider, and we're going to just move forward into social history. You can see that if you're familiar with our other complete evaluations, that this is an abbreviated list capturing just the areas that are most pertinent for the intake team. Are there high-risk psychosocial behaviors? Maybe this patient's eloped in the past and is at risk. Has abuse protective services been called? Is there employment issues? Let's say that this patient, the quality of this patient's work is poor. He or she has difficulty keeping a job. Legal issues, residence status, functioning in school currently and in the past. And let's take a look here at support systems. This patient lives with the family, mom, dad, and there is moderate support among family members. Let's go over here to family history. This is identical, once again, to the family history that we have on our regular complete evaluation. I'm going to say this patient has a sister who has been hospitalized for schizophrenia. She also has a cousin who is treated as an outpatient for schizophrenia, and this is on the maternal side of the family. Otherwise, the past family history is negative. Let's go over here and look at the mental status exam. This is identical to the mental status exam that we have in the rest of the program. If you're not familiar with the rest of the program, I'll put in a quick MSC for a patient who's psychotic. I'm going to say that this patient is, let's see here, guarded, distracted, disheveled, and unhappy. Speech and language are not normal. I'm going to say this patient is garbled, monotonal, slow, and soft in volume. Language skills are fine. Mood, the patient's euthymic. This is clear a patient who is just a clean psychotic patient without a mood disorder. Affect is not normal. Let's go into the C list. I'm going to say that affect is inappropriate and there's inappropriate anger. Go back here. Associations are not intact. I can see the list and say that this patient is not quite word salad, that there's a thought disorder. Let's come back. Our patient's psychotic, so I'm going to go in here to the C list. Once again, I can talk about behaviors being disorganized or bizarre, what types of hallucinations he's hearing, command hallucinations. We've already talked about affect. If the patient's delusional, you can capture that. And up above here, I've already captured the fact that the patient has a thought disorder, so we can go back. This patient has ideas, let's say, but no intention of committing suicide. Denies being homicidal right now. Cognition, dementia, normal, baseline. IQ, baseline is above average. Insight into illness is poor. Social judgment is poor. No signs of anxiety. Attention is distracted and restless. Behavior is somewhat oppositional with poor eye contact. This patient is not withdrawing from drugs or alcohol. You can get in and do a physical exam if you need to, an Ames scale. Let's put in vital signs. Just pop a set in here really quickly. Put down my heading for vital signs first. And I'm just going to type into this area. I'm going to say this patient's a little bit hypertensive. 160 over maybe 95 with a pulse rate of 104. And the pulse rate is regular. Respiratory rate, I'll make this a little bit elevated too, about 23. And temperature's fine. 98.6. You can do a height, weight, BMI, capture some other features here that will show not only in this note, but will be pushed forward into the log area where you can graph it over time. So I'm going to click Done, pop those vital signs in there, and come over here to the summary. And we have two areas here, level of care recommendation and summary of disposition. So for level of care recommendation, if a medical clearance is required for this patient before they get admitted to the psych service, you can click that button. It'll put in a nice paragraph saying that. But I'm going to say this patient is an appropriate admission for an inpatient setting because he has an acute psychiatric condition. Okay. Under disposition, I'm going to say we're going to be admitting to the inpatient setting as recommended. And what type of precautions? I'm going to put this patient on suicidal precautions. Let's see here. I think I said the patient has seizure disorder, so I'll put that down. And observations will be recommended. I might want to say here. Q 15-minute checks. Legal status is voluntary. Let's put down a diagnosis. If you know the diagnostic code for schizophrenia or whatever diagnosis you're looking for, you can simply type in the code here and your diagnosis will display here. If you don't know the code, it's really easy. You can either go into DSM-4, which is becoming more outdated as time moves forward, or we can click in here to the More area, which is going to pull up our DSM-5 work area. The program is by default, we'll choose DSM-5. We're going to work from left to right, and I'm going to click the drop down here, and I'm looking for schizophrenia spectrum and other psychotic disorders. We get a bunch of choices here. I'm going to put down that this patient has, let me see here. Got some other options. Let me see here. I'm just going to put down plain schizophrenia for right now. The status is active. You can always change the status in the future. I'm going to click Done. Okay. I'm going to eliminate access 2 through 5 since I'm using the DSM diagnosis now, and I'm ready to compile this note. I'll take a quick look and see how it looks. This is asking me if I'd like to look at educational resources regarding the diagnosis, labs, and or medications that are prescribed relevant to schizophrenia. And I'm going to say no, but this can be turned on in settings and directories, and you can always print out information from the Compile a Note page. Here's our pre-admission assessment for Julie Jones. It was compiled on today's date at this time. Let's scroll down and just take a look at it. This is a pretty full note. Lots of details, minimal typing, easy to read. And my signature is right here. To make this a legal document, I either print it out and sign it with a pen, or I'm going to come over here and electronically sign it. I'm going to take you back to the chart phase for Julie. And now we can see that pre-admission assessment.